Some headache disorders do not look like headaches at all. They show up as tooth pain, jaw pain, ear pain, or pain deep in the oral cavity. Patients may see multiple dentists, undergo root canals, even surgery, and still the pain keeps returning. This case series is a reminder that severe unilateral orofacial pain with autonomic symptoms may not be odontogenic and may not be a temporomandibular disorder alone. In some patients, the real diagnosis is paroxysmal hemicrania, a rare trigeminal autonomic cephalalgia that can present in the face and mouth, and missing that diagnosis can lead to years of delay and unnecessary treatment. Hi, I'm Dr. Akihiro Ando from Tokyo, and I specialize in orofacial pain and oral medicine. Today, I'm reviewing a recent case series on paroxysmal hemicrania presenting as orofacial pain. This is a very important paper for dentists, oral medicine clinicians, neurologists, and orofacial pain specialists because it highlights a condition that is rare, severe, and very easy to misdiagnose when it presents outside the classic periorbital or temporal pattern. Paroxysmal hemicrania is one of the trigeminal autonomic cephalalgias. Classically, it causes severe unilateral attacks of pain with ipsilateral autonomic signs such as tearing, conjunctival injection, nasal symptoms, ptosis, or facial sweating. The conventional diagnostic description tends to emphasize temporal and periorbital pain. But this paper focuses on something many clinicians may not recognize quickly enough. Paroxysmal hemicrania can present in the maxillary and mandibular distributions, including intraoral pain, and that can make it look very much like dental disease or temporomandibular disorder. The authors performed a retrospective chart review at the University of Minnesota Orofacial Pain Clinic. They screened records from 2015 through 2021 using diagnostic codes related to paroxysmal hemicrania and related headache categories. Out of 5,310 patients seen in the clinic over that time, 36 had at least one paroxysmal hemicrania related diagnosis in the record, but only 4 patients met the final inclusion criteria of initial diagnosis and confirmatory follow-up using ICHD-3 based criteria. So this is a very small case series, but that is also part of the point. This is a rare disorder, and its rarity contributes to delayed recognition. The average age in these 4 cases was 56.5 years, with an equal sex distribution of 2 men and 2 women. All 4 patients had severe, strictly unilateral pain. 3 had pain mainly in the V2 and V3 trigeminal distributions, and 1 had pain involving V1 and V2. Importantly, all patients had intraoral pain, mainly in the teeth and gingiva, and all also had temporomandibular disorder diagnoses. That overlap is one of the reasons these cases are so diagnostically challenging. The pain itself was severe. Patients rated exacerbations between 8 out of 10 and 10 out of 10, with one patient even describing the pain as 20 out of 10. Attacks occurred daily with a mean of about 12.75 exacerbations per day, and attack duration ranged from 4 to 15 minutes typically, although 3 patients sometimes had attacks lasting up to 60 to 90 minutes. That is longer than the classic ICHD-3 description of 2 to 30 minutes, and I think that is one of the most interesting clinical points in the paper. Real patients do not always read the textbook, and some clinically convincing cases may stretch our usual criteria. The pain quality was varied. Patients described burning, throbbing, stabbing, achy, boring, and pulling sensations. That matters because facial pain clinicians often try to classify pain by quality, but this paper reminds us that primary headache disorders presenting in the face may not fit a single simple descriptor. Now, what about the autonomic features? Lacrimation was present in all 4 patients and was the most common autonomic sign. Conjunctival injection and facial edema were also common. Some patients had rhinorrhea, nausea, nasal congestion, ptosis, facial redness, sweating, or even tongue swelling. All autonomic symptoms were ipsilateral to the pain. Clinically, this is critical. When severe unilateral facial or dental pain is accompanied by tearing, nasal symptoms, redness, or other ipsilateral autonomic changes, that should immediately broaden the differential beyond dental pathology. Another major message from this paper is the diagnostic delay. The median delay to diagnosis was about 19.5 months, with the range from 3 months to 6 years. Patients saw multiple providers before the diagnosis was established. On average, they consulted about 5 healthcare providers. Dentists were the most commonly consulted, followed by neurologists. That pattern makes complete sense. When pain is located in the teeth, gingiva, jaw, or ear region, patients and providers naturally think first of dental disease, TMD, sinus issues, or ear problems. And unfortunately, this led to invasive treatments in some cases. 3 of the 4 patients underwent root canal treatment. Other procedures included wisdom tooth extraction, sinus surgery, and even microvascular decompression. This is probably the strongest practical warning in the paper. Rare headache disorders with orofacial presentation can be mistaken for odontogenic pain, and when they are, patients may receive irreversible procedures that do not address the real cause. The comorbidity profile also adds complexity. All 4 patients had painful TMD diagnoses, including myofascial pain, TMJ arthralgia, and disc displacement. 1 had trigeminal neuralgia, and 1 had chronic migraine. Several had a history of trauma, and some had psychological comorbidities such as anxiety, depression, or post-traumatic stress disorder. This reflects real clinical practice very well. Complex pain patients often do not have one clean diagnosis. They may have overlapping disorders, and that makes it even easier to anchor on the wrong explanation. So how were these patients managed? All 4 responded to indomethacin, which remains the hallmark treatment for paroxysmal hemicrania. Maximum dosage ranged from 75 to 225 milligrams per day. However, none of this was straightforward. All patients experienced adverse effects, especially GI problems such as stomach pain, constipation, gastritis, or abdominal fullness. Because of those side effects, patients often could not maintain the higher doses comfortably, and all required adjunctive treatment. That is another valuable point in this paper. We often say paroxysmal hemicrania is indomethacin responsive, and diagnostically that is true and important. But in real practice, tolerability becomes a major issue. A patient may respond biologically to indomethacin and still not do well clinically if side effects prevent adequate dosing. Among the adjuvant therapies, verapamil appeared most effective. It was tried in 3 patients and was significantly beneficial in 2. Gabapentin and pregabalin were also used, though the results were less impressive overall. Carbamazepine helped 1 patient significantly, but had to be discontinued due to side effects. The paper also reports procedural treatments. Sphenopalatine ganglion blocks seemed especially helpful, and auriculotemporal and posterior auricular nerve blocks also provided relief in some cases. I think the treatment section is clinically useful because it shows that management may need to be comprehensive. Even when the diagnosis is correct, treatment may not be as simple as writing indomethacin and stopping there. Dose titration, gastric protection, adjunctive medication, procedural support, and treatment of comorbid pain conditions may all be necessary. The authors make an important conceptual point about classification as well. The classic ICHD-3 description of paroxysmal hemicrania emphasizes temporal and periorbital pain, but the international classification of orofacial pain includes the orofacial counterpart called paroxysmal hemifacial pain. This paper supports the importance of that category. If we do not actively think of trigeminal autonomic cephalalgias in the face and oral cavity, we will continue missing them. Now, we should also be careful not to overstate what this paper proves. This is a retrospective case series of only 4 patients from a tertiary clinic. That means there is substantial selection bias. These are likely unusually complex cases, not a community sample. The prevalence estimate inside this clinic cannot be generalized to the broader population. Also, because this is retrospective, the quality and completeness of historical data depend on chart documentation. So this paper is not giving us incidence, predictive values, or validated diagnostic algorithms. But that does not reduce its clinical value. The value here is pattern recognition. When should this paper change our thinking? I would say in any patient with severe unilateral, recurring facial, dental, gingival, or jaw pain that occurs in short attacks multiple times per day, especially when accompanied by ipsilateral tearing, eye redness, rhinorrhea, swelling, or other autonomic signs. If the pain is dramatic, repetitive, and the dental and imaging workup is unrevealing, we should pause before assuming it is purely odontogenic or purely musculoskeletal. And if the patient also has TMD findings, we should remember that comorbidity is possible. TMD does not exclude paroxysmal hemicrania. Another important lesson is that response to indomethacin may be highly informative, but absolute response is not always as simple in real life as the criteria suggest. Some patients improve substantially, but not perfectly, or they cannot tolerate higher doses long enough to test the response fully. So the indomethacin trial still matters greatly, but interpretation requires clinical judgment. For oral medicine and orofacial pain practice, this paper is especially relevant because it reinforces a core principle. Not all tooth pain is dental pain. Not all jaw pain is TMD. And not all unilateral facial pain belongs to the trigeminal neuralgia family. Some of it is a headache disorder wearing a dental mask. So the practical takeaway is this. Paroxysmal hemicrania can present as orofacial pain, including pain in teeth, gingiva, jaw, TMJ, and ear regions. Diagnostic delays can be long, and patients may undergo unnecessary procedures before the correct diagnosis is made. Indomethacin remains the key diagnostic and therapeutic treatment, but side effects are common, so adjunctive strategies such as verapamil or selected nerve blocks may be needed. Most importantly, clinicians who evaluate facial pain need to actively look for autonomic symptoms and attack pattern because those details may completely change the diagnosis. This paper is small, but its message is large. In facial pain medicine, rare diagnoses matter because the cost of missing them can be years of suffering and irreversible overtreatment. And for that reason alone, paroxysmal hemicrania deserves a place in the differential whenever severe unilateral orofacial pain does not behave like ordinary dental disease. Thank you for watching.